Okay, good morning everyone. Can you hear me?
Good morning, ma'am. Yes, ma'am.
Okay. Can you see the slide?
Yes, ma'am.
So today our topic is anterior abdominal wall part 1. Okay. So the anterior abdominal wall is a musculoepineuritic structure confined to the anterior and lateral aspect of the abdomen. So the wall which is bounding the abdomen anteriorly is known as anterior abdominal wall. So you have to say, when you say the anterior abdominal wall, you have to say the attachment. Okay, you have to say the attachment. Can you see the cursor in the screen? Can you see the cursor?
Yes, ma'am.
Okay, so above it is the intra-abdominal wall is bounded by the xiphoid process. So here we have the xiphoid process. This is the xiphoid process, and below it the anterior part of the iliac crest. This is the iliac crest. Okay, so below it is bounded by the anterior part of the iliac crest, the fold of the groin, pubic tubercle, pubic crest, and pubic symphysis. So above it is bounded by the xiphoid process, below by the anterior part of the iliac crest, the fold of the groin, pubic tubercle, pubic crest, and pubic symphysis. And on each side it is separated from the posterior abdominal wall by the mid axillary line. Okay, by the mid axillary line. Okay, so now there are certain planes in the abdomen. Okay, we have certain planes. These are planes which divides the abdomen into total 9 quadrant. 1, 2, 3, 4, 5, 6, 7, 8, 9. So these are certain planes, and you have to know the landmark of the plane. So the first plane I am talking about is the transpyloric plane. Transpyloric plane. Can you see this cursor in the screen?
Yes,
Yes, ma'am.
yes,
Okay.
sir.
Yes,
Yes,
ma'am.
ma'am.
Okay, you can see, right? So this is a transpyloric plane. Okay, so what is transpyloric plane? The definition is, it is an imaginary horizontal line which passes through the midline of the line joining the jugular notch to the pubic symphysis, and anteriorly it is bounded to the 9 costal cartilage and posteriorly to the L1 vertebra. So in here this plane is known as the transpyloric plane, and it passes this is a imaginary horizontal line which passes between the midpoint of the jugular notch and the pubic symphysis, and anteriorly it is bounded by the 9 costal cartilage and posteriorly by the lower border of L1. Okay, the lower border of L1. See, anteriorly the tip of the 9 costal cartilage and posteriorly through the lower border of L1. So this is a transpyloric plane. Second plane is the intertubercular plane. Intertubercular plane. Why it is called intertubercular plane? Because it joins the two tubercles. These are the two tubercles. It joins the two tubercles of the iliac crest. So the horizontal line passing through the two tubercles of the iliac crest is known as intertubercular plane, and it passes through the upper border of L5 vertebra. So this passes through the lower border of L1 vertebra. This passes through the upper border of L5 vertebra. So this is the intertubercular plane. Next we have we have three vertical planes. These are the two horizontal planes. These are the two vertical, and this is the median plane. Median plane, okay, passes from this, see, lower border of the xiphoid to the pubic symphysis, and these are the mid clavicular plane, mid clavicular line which passes through the midpoint of the clavicle. So these planes divide the whole abdomen into total we have 9 quadrants. These quadrants are important in clinics because certain organs you have to palpate in certain region. So in the middle it is the epigastric region, this is the umbilical region, and this is the pubic region. In the right upper part it is right hypochondriac region, on the left side it is left hypochondriac region. In the middle, right lumbar, left lumbar, and right iliac, left iliac. Okay, now we go to the main thing, that is the layer of the anterior abdominal wall. So the anterior abdominal wall is firm and elastic. It consists of 8 layers from superficial to deep. First we have the skin. Then we have the superficial fascia. Superficial fascia is again divided into two parts. One is the superficial fatty layer and one is the deep membranous layer. Superficial fatty layer is known as Camper's fascia and deep membranous layer is known as Scarpa's fascia. Then we don't have deep fascia. This is wrong in the diagram. Okay, we don't have deep fascia in the anterior abdominal wall. We have the muscle layer. So from out to inwards, from outside to inward, we have external oblique, internal oblique, transverse abdominal muscle or transversus abdominis. Then fascia covering the transverse abdominis is the fascia transversalis. Then we have the extraperitoneal fat, and at the last layer we have the parietal layer of peritoneum. Can you hear me? Okay, so
Yes, ma'am.
just repeat after me, everyone. What is the first layer? In the anteroabdominal wall? What is the first layer in the anteroabdominal wall? First layer, skin. Second layer is the superficial fascia. What are the two layers of superficial fascia? Just now I have told. We have this yellow part is the
Fatty and membranous.
superficial fatty and the deep membranous layer. Do we have deep fascia in the anteroabdominal wall? Do we have deep fascia?
No.
Yes. Why don't we have deep fascia in the anteroabdominal wall? So it is written down, the deep fascia is absent in the anteroabdominal wall to allow the bulging or distension of the abdominal wall after taking meal and during pregnancy. It is also absent in penis, scrotum and perineum. So when you eat, your stomach bulges, right? When you eat lots of food, your stomach bulges. So to allow the distension of the stomach, we don't have deep fascia in the anterior abdominal wall. Okay. What is the next layer? Muscle layer. You kindly respond. First layer of the muscle is what? From outside to inward.
External oblique.
Yes, kindly respond. When I am asking, kindly respond. External oblique, then we have internal oblique, then we have transversus abdominis. And the lower fascia covering the transversus abdominis is the fascia transversalis. Then we have the extraperitoneal fat, and then we have the last layer, which is the parietal peritoneum. Okay. Next, we are coming to the skin. So in the skin, we have many landmarks. We have visible skin crease, midline furrows, linea semilunaris, transverse furrows, line of venous, linea gravidarum, which is prominent in the multiparous. But what is more important in skin is this, the cleavage lines, line which is known as a Langer's line in the anterior abdominal wall. You can see this horizontal lines. These are known as the cleavage line. Important embryologically, the abdominal incisions are preferably given in the cleavage line. Why it is given in the cleavage line? So that it could heal properly. Okay, so that if any incision is given, we mostly give in the cleavage line so that healing is good. Okay, now we come to one more thing very important in the skin is the umbilicus. What is umbilicus? It is a normal puckered scar in the anterior abdominal wall representing the site of attachment of umbilical cord. Okay, regarding the exam point of view, they might ask, in adult it lies at which level? It lies at the level of the intervertebral disc between L3 and L4, normally between L3 and L4. In newborn, it is at a slightly lower level due to poorly developed pelvic region, and in old age it comes down to a lower level due to diminished tone of the abdominal muscle. Okay. Now, very important is the embryological significance. Okay, can you hear me?
Yes, ma'am.
Okay, so whenever I'm teaching any topic in this today's slide, I'm sidewise going to tell the clinical importance. Okay, so kindly note the clinical importance. If I'm talking about embryological significance, next slide I'm going to talk about the clinical importance. So kindly note it. Okay, so embryological significance. What is embryology? What is the embryological significance of the umbilicus? So we have umbilical vessels in we have taught in your model class that in umbilicus we have two arteries, one vein, which passes between umbilical cord and placenta. So the remnant of the umbilical arteries are present in the adult as medial umbilical ligament. Mind you, it is medial, medial, not median. So remnant of arteries, umbilical arteries is the medial umbilical ligament, and remnant of umbilical vein is the ligamentum teres. So embryologically, remnants of umbilicus are ligamentum teres, which is the remnant of left umbilical vein. Always remember, left is left behind. Actually we have two umbilical veins, right and left, but right has been it regresses and left is left behind. So remnant of left umbilical vein is ligamentum teres, remnant of umbilical arteries is two medial umbilical ligaments, and remnant of urachus, in embryology we will study urachus is median umbilical ligament, median, mind you, median. This is medial, this is median. Okay, So you can hear me, right? So what are the remnants? Kindly repeat.
Yes, ma'am.
Okay, so kindly respond. What are the embryological remnants? First one is, what is the remnant of left umbilical vein? What are the remnant? Kindly.
Ligamentum teres.
Yes, ligamentum teres. What is the remnant of umbilical arteries?
Ligamentum teres.
What is the remnant of umbilical arteries? What?
Medial umbilical
No,
ligament.
no, not median. It is medial, medial, L, L. Okay. Umbilical arteries remnant is what? Again repeat. It is?
Medial umbilical
Yes.
ligament. Medial umbilical ligament.
Remnant of urachus. Urachus is? Remnant of urachus is? Respond.
Median umbilical
Median
Yes.
umbilical ligament.
Median umbilical.
Yes, very, very good. So this is the umbilicus. In the diagram you see this is the umbilicus and this is the urinary bladder. So what is connecting the umbilicus and the urinary bladder is the median. Mind you, it is median, median umbilical ligament. And this one from here to here, it is the remnant of umbilical vein. And at the side, this is known as medial umbilical ligament. Medial, always it will be 2, okay, because we have 2 umbilical arteries. And in the between, it is the median umbilical ligament. Okay. Now we are going to the next slide. So these are very, very important. So clinical correlation, we have congenital anomalies in the umbilicus. So number 1 is fecal fistula, failure of vitellointestinal duct to obliterate result in fecal fistula. Okay, fecal fistula, what will happen? What will happen in fecal fistula? Okay, I don't have the diagram here. In fecal fistula, from the umbilicus, fecus will come out. Okay, stool will come out. If there is a fistula connecting the vitellointestinal duct to the umbilicus, then the fecus or the stool will come out through the umbilicus. Okay. Next is the urinary fistula. Failure of urachus to obliterate leads to urinary fistula. What will happen in urinary fistula? Urine will come through the umbilicus. Urine is going to come through umbilicus because this urachus is connecting the urinary bladder to the umbilicus. So if this connection doesn't get obliterate and there is a fistula, there is a pipe fistula connection between the umbilicus and the urinary bladder, the urine from the bladder will come out through the umbilicus. The urine from the bladder will come out through the umbilicus. Similarly, if fecal fistula, there is a thing called vitellointestinal duct which is not shown here. If it is connected to the umbilicus, the stool will come out from the umbilicus. These are the congenital anomalies. Number 3 is the exomphalos or omphalocele. It is exomphalos or omphalocele. It is the failure of midgut loop to return in the abdominal cavity results in exomphalos. Since the intestine protrude through the defect in all the layers of abdomen, at the umbilical ring, a thin transparent membrane, the amnion covers it. So you can see here. You can see the picture, right, everyone? Kindly respond.
Yes, ma'am.
So see
Yes,
what
ma'am.
happens. All this loop, you have seen the inside this intestinal loop. All the intestinal loop has come out through the umbilicus, and this thin membrane covering it is the amnion. So what happens in embryology? First, normally in embryology the midgut tubes come out and then it goes inside. But what happened? Sometimes there is failure of this loop to go inside and it remains outside only. So see what happens from the umbilicus, the whole intestine is outside. This is known as exomphalos. Exom means outside. Omphalocele. Ompha means intestine, loop of intestine. So exomphalos or omphalocele. So this is exomphalos or omphalocele. Sometime you might get this kind of diagram. Okay, in if you give for a NEET PG or any entrance exam, you might get this type of picture. Then you have to make it out. This is exomphalos or omphalocele. They might give you what is this option: fecal fistula, urinary fistula, exomphalos. So you can see the intestine. As you can see the intestine, you have to tell this is omphalocele or exomphalos. Okay, next is the congenital umbilical hernia. Hernia to anything which protrudes out. So what happened in this condition? The intestine protrudes to the umbilicus due to weakness of the umbilical scar and hence it is covered by peritoneum. Okay, mind you, can you see this diagram? Can you see this picture?
Yes, ma'am.
See, what is the difference between the omphalocele and the umbilical hernia? Can anyone tell me? Just now I have read it. What is the difference between the omphalocele and the congenital umbilical hernia? Can anyone respond? What is the difference? You know or not the difference between these two? By seeing only you can tell.
The whole intestine comes out in
No,
eosinophils.
no. See, both the thing in here also the loop comes out. In here also the intestinal loop comes out. The difference is in the membrane. See, this one is the amnion, okay. But here you have the skin, right? You have the peritoneum, okay. In the umbilical hernia, it is covered by peritoneum, and then in above that it is covered by skin. But here you can't see any skin. It is the whole inside out is coming out, right? Kindly respond. Did you understand?
Yes, ma'am.
See, in the congenital umbilical hernia, this hernia is covered by the skin, the peritoneum, the layer of the abdomen. But in the exomphalos, this whole thing is not covered by any skin. This is the amnion. Okay, this is the amnion which is covering the loop of intestine. So in omphalocele, you have to say the midgut loop comes out and it is covered by a layer of amnion. But in congenital umbilical hernia, the midgut loop protrudes to the umbilical scar, but it is covered by peritoneum and skin. So this is the two difference between the two. Okay, next slide is the cutaneous nerves of the anterior abdominal wall. Very important topic. Very important topic. Okay. So what are the cutaneous nerve? So from here you have seen, from this is the umbilicus. At the level of the umbilicus you have T10, okay, T10. Above the umbilicus till the xiphoid process you have T7 to T9. These are thoracic spinal nerves, okay, thoracic spinal nerves. So T10, from above it you will have T9, T8, T7, and below the umbilicus till pubic symphysis you have T11, T12, and also the L1, iliohypogastric and ilioinguinal. Iliohypogastric, ilioinguinal. At the periphery also you have T10, T11. But most important is this T10, because of the visceral pain. We will study later. Because of the visceral pain, this is important. So this is the dermatome here. You can see the dermatome. From xiphoid process, T7, T8, T9, T10. T10 you will have umbilicus, and below that you have T11, T12, and this is the region of, this groin region is the region of L1, that is iliohypogastric and ilioinguinal nerve. Okay, then we have the cutaneous arteries. So we have the cutaneous artery. So the first one is the anterior cutaneous arteries, which are the branches of superior and inferior epigastric artery. So this is the superior epigastric artery. This is the inferior epigastric artery. So you have the cutaneous branches from these two epigastric artery. Then you have the lateral cutaneous artery, which are the branches of posterior intercostal artery. So these are the posterior intercostal artery. So from here you have the lateral cutaneous branches, and also three superficial inguinal arteries, which are the branches of femoral artery. They are superficial external pudendal, superficial epigastric, and superficial circumflex. So here you have the superficial external pudendal, this is the superficial circumflex, and this is the deep circumflex, you can see here. Okay, so mostly if you have to say the cutaneous artery, you have the superior epigastric, inferior epigastric, the anterior cutaneous branches, then the posterior intercostal arteries, lateral cutaneous branches, and superficial branches of the femoral artery, which are superficial external pudendal, superficial epigastric, and circumflex iliac. Now, very important slide is this cutaneous veins. Why it is important? Because of the clinical importance. Anywhere where there is anything regarding the clinical importance, so that topic is very important. So this cutaneous vein accompany the cutaneous artery, and they drain as follow. Below the umbilicus, they run downward and drain into the great saphenous vein in the groin, and thus eventually in the inferior vena cava. So see the arrow, the direction is downward. So this is umbilicus. Below the umbilicus, the vein drain downwards. Always remember, the direction is downwards. Above the umbilicus, they run toward the axilla and drain into the axillary vein and eventually into the superior vena cava. So above the umbilicus, the direction of the arrow is upward. The direction of the drainage is upward. Above the umbilicus, these veins will drain into the axillary vein will drain into the superior vena cava. Below the umbilicus, this vein will drain into the great saphenous vein will drain into the inferior vena cava. Small veins from the umbilicus run along the ligamentum teres to drain into the portal vein. Why I am talking about the venous drainage? Okay, kindly respond. Below the umbilicus, the direction of the flow will be which side?
Downwards.
Downwards, and it will drain into where? It will drain
Downward.
It will drain ultimately where? Superior vena cava or inferior vena cava?
Great. Inferior vena.
This it will drain into the great
Great
saphenous vein,
saphenous
and
vein.
great saphenous vein will drain into the inferior vena cava. Above the umbilicus, it will,
Inferior.
yes, and above the umbilicus the direction will be, above the umbilicus the direction will be, the arrow is
Upward.
upward, and it will drain into the superior vena cava. From axillary vein it will go to the superior vena cava. Why it is important? Very very important is this portal vein obstruction. You will gain,
Upward.
yeah, it will, you will gain you will get short note. Okay, in exam you might get short note on portal vein obstruction or portocaval anastomosis. Okay, very very important topic, portocaval anastomosis or portal vein obstruction. You might get a short note in exam. Okay, or even if you don't get, you have sometimes you have to write in clinical importance. So what is portal vein obstruction? When the venous drainage through the liver is obstructed. Okay, venous drainage to the liver is obstructed, the backflow of the blood may occur. If obstruction is there in the liver, there will be backflow of the blood through the paraumbilical veins. Paraumbilical veins means small small veins near the umbilicus towards the umbilicus. As a result, the paraumbilical vein and superficial vein around the umbilicus becomes grossly distended and tortuous. They radiate out of the umbilicus like a spoke of wheel, spokes of wheel. So you, everybody knows cycle. So you have seen the spokes of the cycle, of the wheel of the cycle. So it becomes like spokes of a wheel, producing a clinical sign which is known as caput medusae. This is very very important. Caput medusae. This condition is also called so because it represents the serpents on the head of Medusa, a mythological lady in Greek mythology. So in Greek mythology, there is a character who is known as Medusa. Did you anybody have heard of her name? Medusa head. You have heard or not?
Yes.
So Medusa head is a
No,
matlab
ma'am.
lady, in her head you have different snakes. Okay, earlier in Cartoon Network also we can see, Medusa, her head has lots of snakes. So from the head snakes are coming out. So that's why the name has come out from this, her only, caput medusa, because the veins are radiating from the umbilicus. Okay, now what is caval obstruction? This is portal vein obstruction. This is caval obstruction. Caval obstruction is the obstruction of superior and inferior vena cava, the thoracoepigastric vein connecting the saphenous and axillary vein. Okay, just now I have told you that above the umbilicus it drains into the SVC, below the umbilicus it drains into the IVC. So if there is an obstruction in the superior vena cava and inferior vena cava, then we have the caval obstruction. Okay, then we have in superior vena cava obstruction and also inferior vena cava obstruction. So this is the caput medusae. See, you can see from the umbilicus you will see engorged tortuous vein radiating outwards. This is the caput medusae. Why it occurs? Because there is obstruction in the liver. Okay, venous flow in the liver, for which there is backflow. There is backflow, and that's why the veins will engorge and it will radiate from the umbilicus like this. Okay, and this is the caval obstruction. These are the thoracoepigastric vein. If you can see this engorgement of this kind of vein, this is the caval obstruction. If in the abdomen you can see this radiating veins, this is caput medusae. This is actually you can see in the clinics when you will go in medicine ward. Sometimes in some patient you can see caput medusae. Okay, from the umbilicus you will see like this veins engorging, and there is a test also. You have to put a thumb here and see. That test you will be taught afterwards in clinics, but this is very important. Caput medusae in portal venous obstruction and caval obstruction in the obstruction of SVC and IVC. Now we come to cutaneous lymph vessels. These are also important. So above the umbilicus, the lymph vessels run upwards to drain into the axillary lymph node. So above the umbilicus, see, the direction is upward to the axillary lymph node, and below the umbilicus the lymph vessel run downward to drain into the superficial inguinal lymph node. So below it will drain into the superficial inguinal lymph node. So follow the watershed line at the umbilicus. Okay. So why it is important? Any tumor or any cancer of the skin in the lower part of the anterior abdominal wall may cause swelling in the groin. Why there will be swelling? Because of the enlargement of the superficial inguinal lymph nodes. And if Above the abdomen there might be swelling in the axilla. So if can you hear me? So in a clinical setting a patient comes to you, okay, in a clinical setting, and everybody can hear me or not now?
Yes, ma'am.
Okay, in a clinical
Yes,
setting,
ma'am.
you are a doctor, okay, and a patient comes to you and you have palpated his axilla. So you might get a swelling in the axilla. So what can you think? Okay, so you have to think in a diagnosis that there might be some obstruction in the lymphatic flow. There might be obstruction in the lymphatic flow. Why there is obstruction in the lymphatic flow? There might be some tumor or infection in the skin, okay, above the umbilicus. If you have swelling in the axilla, you might think in the line of diagnosis, you are the doctor, you have to think there is an obstruction in the lymphatic flow. Why there is obstruction? Because there might be some infection in the skin, or there might be some tumor compressing the lymphatic flow. So you will think in that line and you will give the investigation in that way. If you palpate and there is a swelling in the groin, in the superficial inguinal lymph node, then you will think there is an obstruction in the lymph flow below the umbilicus. Below the umbilicus there might be some tumor, some infection in the skin, which might cause a swelling in the inguinal lymph nodes. So whenever a patient comes and when you do a clinical examination, you have to palpate the lymph nodes. Lymph node palpation is very, very important in clinics. Okay, now we come to next, that is the superficial fascia. So superficial fascia, I have already told you that there are two parts, a superficial fatty layer which is known as chamfer's fascia, and a deep membranous layer which is known as scarpa's fascia. So above the level of the line joining the two anterior superior iliac spine, the superficial fascia consists of a single layer. So above the anterior superior iliac spine, it is single layer, but below anterior superior iliac spine, it consists of two layers. So if they ask you superficial fascia is two layers, from which demarcation, you have to say below the anterior superior iliac spines. Okay. Next, okay, now what is Camper's fascia? It is already I have told you, it is a fatty layer which is continuous with the superficial fascia of the adjoining areas of the body. Over the penis, mind you, over the penis, it is devoid of fat, okay, and in the scrotum, and this Camper's fascia is replaced by a involuntary muscle which is known as dartos muscle. In later afterwards, when you will study the lower limb properly or the groin, then you will come across this muscle, that is the dartos muscle. It is nothing but the superficial Camper's fascia which is replaced, okay. Then scarpa's fascia, it is a deep membranous layer of superficial fascia of the abdomen and is made up of elastic type of fibrous tissue. In the midline, the scarpa's fascia is attached to the linea alba. On each side, it is separated from the underlying oblique muscle by a layer of loose areolar tissue. Okay, below it crosses the inguinal ligament and get attached to fascia lata, and it is prolonged over the penis to enclose it up to the base of the glans to form the fascia of the penis, Bach's fascia. So Camfer's fascia becomes dartos muscle in the penis, and the Scarpa's fascia becomes the Bach's fascia in the penis. Okay, fascia of the penis. So these two are the replacement which you have to know. Okay, over the scrotum, the Scarpa's fascia, it covers the scrotum where it is replaced by dartos muscle, and then continue with the superficial fascia of the perineum. So Scarpa's fascia is continuous with the superficial fascia of the perineum, that is the Collis fascia. Now, the Collis fascia is attached to the posterior edge of the urogenital diaphragm. Attachment of Collis fascia is important because there is a clinical importance here. So, you have to know this. The Collis fascia is attached to the edge of the urogenital diaphragm, which also stretches across the pubic arch. The space between the perineal membrane and the Collis fascia is known as superficial perineal pouch. This is very, very important. So you can see this is a Collis fascia. Okay, this is the Collis fascia. This is a fascia of the perineum, and the space between this is the perineal membrane. Okay, the space between the perineal membrane and the Collis fascia, this space is known as the superficial perineal pouch. Very, very important clinical wise. So in here in this diagram you can see this is the fatty campus, this is a deep membranous layer. Okay, so and this is the dartos muscle. See, dartos muscle, I have told you this dartos muscle is the campus, this campus fascia only, which is replaced in the penis. So this is the dartos muscle, this is the Collis fascia in the perineum, and this is the perineal membrane. So this space is the superficial perineal pouch. Here also you can see in this diagram superficial fascia of the abdomen. So below the anterior superior iliac spine it is divided into two, that is the campus fascia and the deep membranous, which is deep. This is the blue color is the scarpus fascia, deep membranous, and this yellow color is the campus fascia. Okay, now very important is the line of attachment of scarpus fascia with fascia lata is marked on the surface by Holdens line. Holdens line. It is asked in the viva, what is Holdens line? Okay, which begins a little lateral to the pubic tubercle and extends laterally for about 8 cm. A potential space exists in the anteroabdominal wall between the scarpus fascia and the aponeurosis of external oblique, and this is termed as superficial inguinal space. Okay, what is Holdens line? The line of attachment of scarpus fascia with fascia lata. So this is the fascia lata, this green color is the fascia lata, and this is the scarpus fascia. So wherever it is attached, the line of attachment of fascia lata with scarpus fascia is the Holdens line. Okay, now respond. What is Holdens line? Anyone? Can you hear
The
me?
attachment of scarpus fascia with the fascia lata is called Holdens line.
Very good. This is the Holdens line. This is blue color is the scarpus fascia. This is the fascia lata. So this is the line of fusion, and this is known as Holdens line. Very important clinically, and this question is asked by all our professors in the exam. Okay, so you have to tell the line of fusion of membranous layer, that is scarpus fascia with fascia lata, is the Holdens line. Okay, very see, now we have come to the clinical significance. That's why I was concentrating on Collis fascia, Holdens line. Why? The attachment of scarpa and Collis fascia are such that it prevents the passage of extravasated urine if there is any injury to the urethra, that is urethral rupture, then backward into the ischiorectal fossa and downward into the thighs. So the line of fusion of scarpus fascia over the Holdens line, body of pubis and margin of the pubic arch, and the posterior border of the perineal membrane of the posterior edge of the urogenital diaphragm. Therefore, if the male urethra is ruptured in the perineum, the extravasated urine collects first in the superficial pouch of perineum and then onto the anterior abdominal wall to the umbilicus in the superficial inguinal space. The presence of the urine in this confined space where the scarpus fascia is attached makes the clinician to suspect that the urethral rupture is due to trauma. Clinically, rupture of the urethra in the perineum presents as swollen perineum, swollen scrotum, swollen penis, and swollen lower part of the abdomen. Now, why I am talking about the Holdens line again and again? Why? Because see, this is the Collis fascia. This lining is the Collis fascia. Okay, this is the Collis fascia, and here we have the urethra. And there is a attachment of scarpus fascia with the fascia lata, that is the Holdens line. So if there is any injury in the urethra, any rupture in the urethra, the urine will extravasate. Okay, it will come, this yellow is all the urine will come, it will surround the scrotum. This is the scrotum, the urine is surrounding the scrotum, the urine is surrounding the penis, the urine might surround the perineum, and the urine is surrounding the lower part of the abdomen. But mind you, the urine is not going down to the thigh. Below the thigh, the urine is not going down. Why the urine is not going down below the thigh? Can anyone tell me?
Because of inguinal ligament.
No, because of the Holdens line. Okay, there is a firm attachment of the scarpus fascia to the fascia lata. So the urine is not going down below the Holdens line. Okay, you understood or not? If you have not understood, again I.
Yes, ma'am.
So what happen if there is any injury in the urethra? This question might come. Okay, in your exam, in your internal exam, you will not get direct question. They will give you, if a person has fallen down in a manhole. Okay, you know what is manhole? In footpath you have seen manhole or not? Respond. In footpath you have seen manhole or not?
Yes,
Manhole.
ma'am.
Okay, that this question came in my exam. That's why I'm repeating again. In PG exam it came. If a person is walking by a footpath and he has fall on the manhole, okay, what injuries the person can sustain? The question came like that. So the injury will be in the, if a person has fallen down on the manhole, then the person might injure his genital area and also the urethra. There might be rupture of the urethra. So if a person has fallen down in the manhole, there might be rupture in the urethra. If there is rupture in the urethra, the urine will deposit in the superficial perineal pouch. This is the superficial perineal pouch. The urine will collect in the superficial perineal pouch and also the superficial inguinal space. So in what region urine will collect? What is this? Tell me, respond. What is this? Can you hear me or not?
Yes, ma'am.
What is this? What is this? The urine will collect in the scrotum, around the scrotum. The urine will collect around
Yes,
the
ma'am.
penis. There will be swelling in the penis. There will be swelling in the scrotum. In female, there will be swelling in the perineum. There will be urine deposition in the lower abdomen. But the urine will not go down below the thigh because of
Holding shell.
Means Holdens
Holden's line.
line.
Yes, very, very good. Okay, means you have understood. Now we come to the muscles of the anterior abdominal wall. So we have total 5 pairs of muscle, 5 on either side of midline, 3 flat muscles and 2 vertical muscle. The 3 flat muscles are external oblique, internal oblique and transversus abdominis, and the 2 vertical muscles are rectus abdominis and pyramidalis. And the neurovascular structure lie between internal oblique and transversus abdominis. This is an MCQ which might come in your exam. The neurovascular structure will lie between the internal oblique and transversus abdominis, not between external and internal. The neurovascular bundle, that is the vein, arteries, nerve, they will lie between the internal oblique and transversus abdominis. Now we come to external oblique muscle. So external oblique muscle arise from 8 fleshy slips from the outer surface, that is the middle shaft of lower 8 ribs. Insertion runs, very important, downward, forward, medially, in the same direction as the fingers do when you put the finger inside the side pocket of your apron. Okay, the free lower border of epineus is thickened and roll inward on itself to form the inguinal ligament. Okay, anyone, can you answer me? Inguinal ligament is formed by?
Holding of external oblique
Yes,
aponeurosis.
external oblique aponeurosis, lower free border. Okay, very favorite question of your professors. The lower free border of the external oblique aponeurosis will thicken and it will rolled inward. Very important term, rolled inward to form the inguinal ligament. Inguinal ligament is nothing but the continuation of the external oblique aponeurosis, which becomes thickened and it will roll on itself to form inguinal ligament. Okay, and what is the direction of external oblique muscle? It is downward, forward, medially. When you put both of your hands inside the pocket of your apron, okay, when you put both your hand inside the pockets of your apron or inside both the pockets of your pen, the direction of your fingers downward, forward and medially, that is the direction of the muscle of external oblique aponeurosis. That is the direction of the muscle of external oblique aponeurosis. So this is the direction, like putting the hand in the pockets, downward, forward and medially, downward, forward and medially. Then we come to the origin from the 8 fleshy slips of the outer surface of lower 8 ribs. Okay, the upper 4 slips with the serratus anterior and lower 4 slips with the latissimus dorsi. Insertion into the anterior 2/3 of the outer lip of iliac crest and also into the xiphoid process, linea alba, pubic symphysis, all the midline structure. Nerve supply will be T7 to T12. So See 7, 8, 9. Okay, from the low downward slips, this is the origin, and insertion you can see this is the anterior two-third of the iliac crest. Also this is the linea alba. Okay, linea alba, then you have pubic symphysis, pubic crest. Okay, this is the insertion. This means midline structure is the insertion. It has become aponeurotic. See, it has become aponeurotic, and this is the origin from the lower 8 slips of the lower 8 ribs. Okay, this is the external oblique muscle. Then we come to internal oblique muscle. Okay, before that I want to show you one more diagram. Okay, the internal oblique muscle is relatively smaller and thinner than the external oblique. It lies deep to the external oblique, and our fibers are oriented at right angles. So this is the internal oblique. Okay, it is at right angles to the external oblique. This is the internal oblique. If you remove the external oblique, you will get internal oblique. So this is the external oblique, this is the internal oblique. The direction is opposite to the direction of external oblique, and it is at right angles. It is at right angles. This is the direction. So the direction is at right angle to the external oblique. Okay, so the origin is from the lateral two-third of inguinal ligament and anterior two-third of intermediate area of iliac crest, and also the thoracolumbar fascia. And the insertion is the inferior border of the lower third and fourth ribs, and the aponeurosis into the 7, 8 and 9 costal cartilage. The nerve supply is T7 to T12 and also L1. So here you can see this is the origin. Okay, iliac crest, this is the origin, and insertion third and fourth ribs, you can go there. Okay, so this is the origin, this is the insertion, and the nerve supply is same only T7 to T12 but also L1, and the direction of internal oblique aponeurosis is at right angles to external oblique aponeurosis. So kindly respond to me, what is the direction of external oblique aponeurosis? Yes, it is like putting your hand in your pocket, right? What is the direction of internal oblique aponeurosis? Right angle to
At right
external
angles
oblique.
to external.
Yes, very very good. Right angle to external oblique. Okay, you have understood means. Now we are going to transversus abdominis. So if you cut the internal and external, you will get transversus abdominis. It is the innermost of the three flat abdominal muscle, and the direction is horizontal. So what is the direction of transversus abdominis? It is in the word only. Transverse means horizontal. So direction is horizontal. And what is the origin? Lateral one-third of the inguinal ligament, and anterior two-third of the inner lift of iliac crest, thoracolumbar fascia, and lower 6 costal cartilage. And insertion is aponeurosis into xiphoid, linea alba, pubic crest, pectineal line, and same nerve supply same. So see the origin. What is the origin of the transversus abdominis is from the lateral one-third of the iliac crest, and lateral, it is two-third was for the internal oblique, and one-third is for the transversus abdominis. And this fascia, no, backside, it is known as thoracolumbar fascia. It is also originating from the thoracolumbar fascia, and it is get inserted in this. See, this is the aponeurotic thing, this midline structure. I have told you, linea alba, pectineal line, pubic crest, all this it is getting inserted here. Okay, and the nerve supply is same only T7 to T12 and L1. Okay, this is transversus abdominis. So in here you can see this is the external oblique. If you cut this, you will get the internal oblique. Okay, and then if you cut both external and internal, you will get this, you will get the transversus abdominis. You will get this transverse muscle which is known as transversus abdominis. Now we come, what are the structures derived from the flat muscle? Okay, anybody tell me, inguinal ligament is derived from? Inguinal ligament is derived from?
External oblique
Yes,
aponeurosis.
very very good. It is the lower free border of external oblique, not muscle. You have to say external oblique aponeurosis. Don't tell muscle, you tell aponeurosis. Okay, external oblique aponeurosis. So it is a lower free border of the external oblique aponeurosis. Conjoint tendon. It is formed by the fusion of lower aponeurotic fibers of internal oblique and transversus abdominis muscle, which arches over the spermatic cord and is attached to the pubic crest and medial part of pectineal line. So conjoint tendon is formed by, okay, conjoint tendon is formed by what? Tell me. See, I have marked it. What is this?
Internal
Yes, aponeurosis of internal oblique and transversus abdominis. So conjoint tendon is formed by aponeurosis of internal oblique and transversus abdominis. Asked in viva, favorite question of our head and our professors. Okay, very favorite question. Okay, so conjoint tendon is formed by internal oblique and transversus abdominis aponeurosis, and inguinal ligament is formed by external oblique aponeurosis. Now cremaster muscle is very important because of the clinical importance. We have a clinical importance known as cremasteric reflex. In clinics, when you will go to surgery ward, you might be given to do cremasteric reflex. So what is cremaster muscle? Consists of a series of loop of skeletal muscle fibers joined by loose areolar tissue, cremasteric fascia. They form the covering around the spermatic cord and testis. These are derived from lower fibers of internal oblique. The medial ends of the loops are attached to this pubic tubercle, pubic crest and conjoint tendon. Important is the cremaster muscle is supplied by the sympathetic fibers of L1 and L2 spinal segment through the genital branch of genitofemoral nerve. Okay, genital branch of genitofemoral nerve, and it is not under voluntary control. So you can't control the reflex yourself. It is involuntary. Okay, it is involuntary. This is the clinical correlation. Clinical correlation is the cremasteric reflex. So what happened if you stroke the skin of the upper medial aspect of thigh? Okay, if with a pen or with a small feather or with a needle, if you stroke the skin of the upper medial aspect of thigh, there is a reflex contraction of the cremasteric muscle leading to the elevation of the testis. So the testis will be elevated. This reflex is more brisk in children. Why this reflex is formed by the femoral branch of genitofemoral nerve. Why this reflex occurs? The femoral branch of genitofemoral nerve forms the efferent limb, and the genital branch of genitofemoral nerve forms the efferent limb, and the reflex center is L1 L2 spinal nerve. So here you can see this is the spinal segment and this is the testis. We have the genitofemoral nerve and we have the femoral branch and we have the genital branch. So this forms a reflex, efferent and efferent. So if you stroke with a pencil or with a needle near the thigh, what will happen? This testis will elevate, and this is under not voluntary control, it is involuntary. Okay, so this reflex is important, for which cremaster muscle is very important. Okay, now we come to the vertical muscles. Two vertical muscles are the rectus abdominis and the pyramidalis. Okay, pyramidalis is a very small muscle and rectus abdominis is a bulky muscle. So it is a long flat strap muscle, rectus abdominis, which extends vertically upward along the linea alba from the pubic symphysis below to the costal margin above. It widens as it ascends from the pubic symphysis to the costal margin, and thus it is wider above and narrow below. So this whole bulk of muscle, this whole bulk of muscle is the rectus abdominis muscle. So you know, rectus muscle, so you have to know, the boys should know the rectus muscle if you want to make abs. Very important. So rectus abdominis is a vertical muscle. Okay, it is a vertical flat muscle. It's a vertical flat muscle. The origin is by two tendinous head. We have medial head and lateral head. Medial head arises from the anterior surface of pubic symphysis, and lateral head arises from the lateral part of pubic crest and pubic tubercle. So you have the pubic symphysis here. So medial head from the middle part of the pubic symphysis, lateral part from the lateral part of the pubic crest and pubic tubercle. Okay, so this is the origin. We have two origin, that is the medial head and the lateral head. The insertion is on the anterior thoracic wall by four fleshy slits along the horizontal line, passing laterally from the xiphoid process and cutting in 7th, 6th and 5th costal cartilage. So insertion will be somewhere here. So this whole bulky muscle is the rectus abdominis muscle. Okay, the muscle presents three tendinous intersections. Why I am talking this muscle is important to make packs, 8 pack, 6 pack, 7 pack. You have 7 pack or not? Tell me. You have 7 pack or not? I am talking about 7 pack. Is there any 7 pack?
No, ma'am.
No. Okay, so we are talking about the 8 pecs, we are talking about the 6 pecs. Why the pecs occur? Because of the tendinous intersection. This white thing you can see, no? These are the tendinous intersection. These are the tendinous intersection which converts the rectus muscle into the 8 pecs, 6 pecs. Okay, so the muscle presents 3 tendinous intersection. First at the level of tip of the xiphoid process, second at the level of the umbilicus, and third at the level midway between the above two. Sometimes a fourth intersections may occur. So if a fourth intersection occurs, then you might get an 8 pec. Okay, if a fourth intersection occur, then you might get an 8 pec. Normally we have 3 intersection. If we have 3 intersection giving you 6 pecs. Okay, so we have 3 intersections. If these intersections are very much prominent, and if your this muscle are very much toned, then you can see the pecs. Okay, and if you have less fat in the anterior abdominal wall, then your this muscle is very prominent and you can see as pecs. Okay, so these are the intersections. Each intersection pass horizontally in zigzag manner and is attached to the anterior wall of the rectus sheet. We'll come to the rectus sheet in the next topic. The tendinous intersection divides the long muscle column into shorter segments to provide more strength. What is the function of the tendinous intersections? It provides more strength. The muscle is enclosed in aponeurotic sheet derived from 3 paired anterolateral flat muscle of the abdominal wall. So the nerve supply of rectus abdominis is same T7 to T12, and action is flexion of the trunk on the pelvis. Flexion of the trunk on the pelvis. Okay. Now we come to pyramidalis. Pyramidalis, very small muscle. So see, you can see the small muscle here, pyramidalis. Mostly it is absent in 20% of the people. This is a small muscle, vertical muscle, that is the pyramidalis. It is rudimentary in human beings. Small triangular muscle lying anterior to the lower part of rectus abdominis within the rectus sheet. It has a base below and in front of the pubis, and its apex is above and medially. So this is a triangular sheet muscle, vertical muscle, triangular muscle. The base is below and apex is above, and it just lies in the lower border of the rectus muscle. So this is pyramidalis. Origin is from the front of the body of the pubis and the pubic arch. Insertion is in the midline, linea alba. Okay, linea alba. Nerve supply is T12 and it tenses the linea alba. So this is pyramidalis. Now what is the function of abdominal muscle? Function of abdominal muscle, 3 main function: to provide strong expandable support of the abdominal viscera against the gravity and to protect them from injury. Also to compress the abdominal content, to increase the intra-abdominal pressure and thus help in expulsive and expiratory acts, and to move the trunk to maintain the posture. So these are the 3 main function of the anterior abdominal wall. Now very important topic is the rectus sheet, and rectus sheet comes as short note. Okay, so tick mark, triple star, quadruple star, whatever star you want to put, this will come as a short note. Rectus sheet, very important topic, and every time it comes as a short note. So what is rectus sheet? It is an aponeurotic sheet enclosing the rectus abdominis muscle. So the rectus abdominis muscle is enclosed by a aponeurosis which is known as rectus sheet, and also sometimes pyramidalis. It is derived from the aponeurosis of flat muscles of the anterior abdominal wall. The function of the rectus sheet is checking the bowing of the rectus muscle during its contraction and hence increasing its efficiency, and also maintaining the strength of the anterior abdominal wall. Features: it presents as anterior and it has 2 walls, anterior and posterior wall. Anterior wall is complete and covers the entire extent of the muscle longitudinally from upper to the lower end. Okay, anterior wall is complete, but the posterior wall is deficient from above and below, and hence does not cover the entire extent of the muscle. Okay, so in rectus sheet, can you hear me? Rectus sheet, the anterior wall is complete and the posterior wall is deficient. Okay, very important. Anterior wall is complete and the posterior wall is deficient. Above, it is attached to the costal margin, 7, 8 and 9 costal cartilage, and lies directly on 5th, 6th and 7th costal cartilage. Okay, and below it is present as a free curved margin with concavity facing inferiorly, known as arcuate line or line of Douglas, between the umbilicus and pubic symphysis. Below this level, muscle lies directly on fascia transversalis. So what is arcuate line? Next question asked in exam. What is arcuate line? Anyone kindly respond. What is arcuate line? It is written here.
Between umbilicus and pubic symphysis.
It is the curved margin of rectus sheet. Okay, the lower free curved margin of the rectus sheet is the arcuate line. You can see the arcuate line in the dissected body also when we dissect the abdomen. Okay, so this is the rectus muscle. This whole muscle is the rectus muscle, and this is the aponeurosis covering the rectus muscle, and this aponeurosis is complete anteriorly and deficient posteriorly. Above and below it is deficient, only in the middle it is present. So the anterior wall of the sheet is complete anteriorly, but the posterior wall is deficient above and below. In the middle it is present, and arcuate line is the lower curved margin of the rectus sheet. This line is known as the arcuate line, lower curved margin of the anterior sheet. So this topic, formation of rectus sheet, you have to draw this diagram. Okay, you have to draw this diagram and you have to tell how it is formed. So there are three parts, first, second, third, and every part has different formation. So kindly you try to understand with me. Above the level of the costal margin, so above the level of the costal margin, I told you anterior wall is complete, posterior wall will be deficient above and below. It is present only in the middle. So above the level of the costal margin, posterior wall is deficient. See, I told you now, above it is deficient, and the muscle will lie directly on 5th, 6th and 7th costal cartilage. See, since there is no posterior wall in the above the costal margin, the first diagram is this one. Above the costal margin, the green color is not there posteriorly. You have seen here, there is no green color posteriorly. So the rectus muscle will directly lie on 5th, 6th and 7th costal cartilage. 5th, 6th and 7th costal cartilage. Okay, it will lie directly on this costal cartilage, and this green color is the rectus muscle. This is the external oblique aponeurosis. Okay, so this is the rectus muscle, rectus aponeurosis. Sorry, this is the rectus aponeurosis, or that is the rectus sheet. This green color is the rectus sheet. This is the rectus muscle, and there is no posterior wall, so it lies directly on the 5th, 6th and 7th costal cartilage. This is above the costal margin. Between the costal margin and the arcuate line, between the costal margin and the arcuate line, the posterior wall, you see the posterior wall, it is not deficient here. In between it is not deficient, above and below it is deficient. So between the costal margin and the arcuate line, the anterior wall is formed by fusion of aponeurosis of external oblique with the anterior lamina of internal oblique aponeurosis. So this is the external oblique, this is the internal oblique. This internal oblique has two lamina, anterior and posterior lamina. Okay, this internal oblique aponeurosis, everybody see in the diagram, this is external oblique, this is internal oblique, this is transversus abdominis. Okay, this is external oblique, this is internal oblique, this is transversus aponeurosis abdominis, and this green color is the rectus sheet. This is the rectus sheet which surrounds the rectus muscle. So this part is the anterior wall and this part is the posterior wall. So above the costal margin, this posterior wall is deficient. Between the costal margin and the arcuate line, you have the posterior wall. Okay, and below the arcuate line, again the posterior wall is deficient. Now in between the costal margin and the arcuate line, the anterior wall, this anterior wall is formed by the aponeurosis of the external oblique and the aponeurosis of the internal oblique, but internal oblique has two lamina, anterior and posterior. So anterior lamina of the internal oblique, the aponeurosis of the external oblique forms the anterior wall, and posterior lamina of the internal oblique and aponeurosis of the transversus abdominis forms the posterior wall. Then below the arcuate line, the anterior wall is formed by the aponeurosis of all the three muscles, internal oblique, external oblique, internal oblique, and transversus abdominis. This all the three muscles aponeurosis form the anterior wall, and posterior wall is again deficient here. So below the arcuate line, posterior wall is deficient. Above the costal margin, posterior wall is deficient. It is present only between the costal margin and the arcuate line. Okay. Now we come to the recent view of the rectus sheet formation. Here I have shown that there are 3 points in the formation, but again there is a recent view also. It is found that aponeurosis of all the 3 flat muscles are bilaminar. Okay, the recent view, sometimes they might ask that all the 3 muscle aponeurosis are bilaminar and give 6 lamina in all 3. Okay, now contents of the rectus sheet. We have 2 muscle, that is rectus abdominis and pyramidalis. We have 2 arteries, that is superior and inferior epigastric. We have 2 vein, superior epigastric and inferior epigastric vein, and we have 6 nerves, that is terminal part of lower 6 thoracic nerves, including the lower 5 intercostal nerves and subcostal nerves. So we have total 6 nerves, 2 vein, 2 arteries, 2 muscles. Okay, so this is the nerves and arteries. We have superior epigastric artery, inferior epigastric artery, also superior epigastric vein, inferior epigastric vein, and we have lower 6 nerves, that is T7, T8, T9, T10, T11, T12, and the total 6 nerves we have. So contents we have to see that. Okay, now important about the rectus sheet is the pedicle of the upper part of rectus abdominis muscle on the superior epigastric artery is sometimes used in reconstructive surgery of the breast. So in reconstructive surgery of the breast, sometimes the upper flap of the rectus abdominis muscle is used. Second is the divarication of the recti. What is divarication of the recti? If the rectus abdominis muscle separates, it is known as divarication. When does it occurs? Normally in an elderly multiparous woman, if a woman has given birth to several child, it will have a weak abdominal wall. So in this condition, the aponeurosis of the rectus will become excessively stretched, and if the patient coughs or strains, the recti will separate widely, and a hernial sac containing loop of intestine will protrude between the margins of the recti. So this is known as divarication of recti. Then we have hematoma of the rectus sheet. So sometimes the superior and inferior epigastric arteries are unduly stretched, and during a severe bout of coughing in later months of pregnancy, and they might be exposed to trauma, so there might be hematoma in the rectus sheet. It is usually present in some midline abdominal pain and tender mass. So here you can see there is divarication. The rectus muscle has splitted, divarication of rectus abdominis. And also we have epigastric hernia. So this is a midline hernia, a midline fibrous raphe. If the rectus becomes weak, so in elderly multiparous women, the hernia, you might see a hernia here. So it is known as epigastric hernia, and there might be protrusion of fat in this hernia. Okay. Now what are the deep nerves of the anterior abdominal wall? So deep nerves are mostly T7 to T11, subcostal nerve, that is T12, and we have iliohypogastric, ilioinguinal. Okay, these are the deep branches of deep nerves. So motor branches mostly supply the internal, external, transversus and rectus. Okay, T12 supplies the pyramidalis. L1 and L2, it supplies the internal oblique and transversus abdominis. Okay, these are the motor, and then we have the cutaneous branches. Also we have deep arteries, that is superior epigastric, musculophrenic, inferior epigastric and deep circumflex. Okay, the next layer is the fascia transversalis. Fascia transversalis is the fascia, it is a thin fascia that lines the inner surface of transversus abdominis muscle. The thin fascia covering the inner surface of transversus abdominis muscle is known as fascia transversalis. Superiorly it is continuous with the inferior aspect of the diaphragm, that is the diaphragmatic fascia, and inferiorly it is with the fascia lining the iliacus muscle, that is fascia iliaca. Anteriorly it extends to linea alba and becomes adherent, and posteriorly it becomes continuous with the anterior layer of thoracolumbar fascia. So this is the fascia transversalis. This whole is the fascia transversalis. Okay, so it will line the inner layer of the transversus abdominis. This is transversus abdominis, and innermost lining of this transversus abdominis is the fascia transversalis. Anteriorly it is above it is continuous with the diaphragmatic fascia, below it is continuous with the fascia iliaca and also the pelvic fascia. Okay, so this is fascia transversus. Now we come to the abdominal incision. We have midline incision, pyramidal incision, McBurney's incision, Coucher's incision and transverse incision. Midline incision, it is given in the midline along the linea alba. An advantage is that it is mostly bloodless, there are no muscle fibers and no nerves are injured, and gives access to both sides of the abdomen. So this is the upper midline and this is the lower midline incision. Okay, but bloodless incision, this is the midline incision. Then we have the pyramidal incision. Okay, pyramidal incision, just parallel to the midline is the pyramidal incision. This is the pyramidal incision. In surgery it is important. Then we have McBurney's incision. McBurney's point is very important. McBurney's point, it is this incision, it is given for appendicectomy. When you want to do appendix surgery, then we give the McBurney's incision. It's an oblique incision in the right iliac fossa, 5 cm above and medial to anterior superior iliac spine at the right angle to spino-umbilical line. Okay, it has no post-operative weakness. So this is the McBurney's point. Okay, so if you draw a line between the umbilicus and the anterior superior iliac spine, this is the line drawn, and if you take the point between the medial 2/3 and lateral 1/3 in the right iliac fossa, this is the McBurney's point, and if you give an oblique incision here, it is known as McBurney's incision or gridiron incision for appendicectomy. Okay, then we have Coucher's incision or right subcostal incision. It is due to expose the gallbladder. Okay, it is parallel to the right costal margin. This is the Coucher's incision. If you want to expose the gallbladder, then we give the Coucher's incision or subcostal incision. And also we have transverse incision in the lower abdomen. Okay, it is to explore the pelvic organ, and surgery is related to uterus. So this is the transverse incision. Okay, so with this I am going to finish the class. Everybody understood or not?
Yes, ma'am.
Yes, ma'am.
Okay, so tell me, inguinal ligament is made up of?
External oblique aponeurosis.
Very good. External oblique aponeurosis. Conjoint tendon is consist of conjoint tendon.
Ma'am, lower appendicular fibers of internal oblique and transverse abdominalis.
Very good. Lower appendicular fiber. Okay, now tell me, the posterior wall of rectus sheet is deficient where? Where it is deficient? Posterior wall is deficient above and below. Okay, above the costal margin, below the arcuate line. So posterior wall is deficient above the costal margin, below the arcuate line, but in middle it is present. Okay, so rectus sheet is the aponeurosis covering which muscle?
Rectus muscle.
8
Rectus
pecs
abdominis.
muscle. It is covering the rectus abdominis muscle. So the pecs, 8 pecs, 6 pecs are due to the 3 tendinous intersections which strengthens the muscle and divides the muscle into different segments. Okay, thank you so much. Understood, no?
Yes, ma'am.
Okay,
Yes,
last
ma'am.
question. McBurney's incision is given for which surgery? McBurney's incision is given for which surgery? McBurney's incision is given for which surgery? Right iliac fossa. What structure is present? Appendix.
Appendix.
So, appendicectomy. Coucher's incision is given in which surgery? Coucher's incision. Coucher's. Gallbladder.
Gallbladder.
Yes, gallbladder. McBurney's is for the appendix and Coucher's is for the gallbladder. Okay, thank you so much. So I have taken a reference from Vishram Singh. Mostly all the things are in Vishram Singh. If you study the book, my whole slide is from Vishram Singh. So you just see the Vishram Singh textbook of anatomy and lower abdomen, and some of the photo I had taken from internet. So thank you so much. Thank you everyone.
Thank you, ma'am.